Conversations in Medicine. This program brings cutting-edge medical topics to the Staten Island and tri-state community. Today's topic is about obstetrics, and we've come a long way in obstetrics from years and years ago, where mortality rates and moms would die frequently, and sometimes moms would be asked, or families would be asked, is it the mother or the child that will survive? Now we've come a very, very long way, thank goodness. And I have a wonderful guest with us tonight, Dr. Simon Kokkinakis, a good friend, an attending obstetrician and gynecologist at Richmond University Medical Center, really one of the preeminent obstetricians on Staten Island, someone who I know for many years. And it's really a pleasure to have you on the show here tonight. Thank you.
Thank you, Dr. Perel. Thank you for inviting me. Pleasure to be here with you tonight.
Thanks. So we're going to jump right in. Tell us all, we see the word OB, OBGYN, gynecologist, obstetrician. Tell our audience, what's an obstetrician?
An obstetrician is the doctor who follows your pregnancy, the doctor who takes care of the pregnant woman from start to finish, from conception to delivery to postpartum and many, many years beyond.
What training, an obstetrician is a physician. I'm
Absolutely.
A neurologist with one type of physician, obstetrician clearly another type. Tell me a little bit about the training of someone from college on to become an obstetrician.
An obstetrician, medical doctor, we do 4 years of medicine or medical school, and then 4 years of a rigorous residency program, including surgery. And then we have the opportunity to specialize and do a fellowship. Typically, those are 3 years. We have reproductive endocrinologists who are the physicians that deal with infertility, help patients get pregnant when they're having difficulties becoming pregnant. Maternal fetal medicine specialist, which is a doctor who takes care of high-risk pregnancies. They're much more specialized in high-risk pregnancies, and the trade-off is they do no or minimal gynecology. And then you have the gynecologic oncologist who specializes in taking care of gynecologic cancers.
For the last 2 years, we've all in our practices and our lives been going through COVID-19. Tell me a little bit, how's it affected you and your practice and your team at the hospital? And even how's it affected your patients, the pregnant women who during this very, very difficult time and stressful time?
COVID, thinking back 2 years ago, when COVID hit, it was very difficult. We didn't know what was going on. We didn't know what to expect. We didn't know much about it back then. Mm-hmm. It's gotten much better. It's gotten much better now. I always remember one of our ICU attendings who always says, today's a better day. Not as many people died today, and now I have him saying nobody died. So we're getting to a good place with COVID. However, in the beginning it was difficult. Patients were coming in. We didn't have testing or testing in the hospital done on every laboring patient as we do now, and we would find out later on. So it was difficult to have to tell a mom that you have COVID and your newborn could be affected. But luckily, with the team of doctors that we have at Richmond University Medical Center, babies were being discharged. Thank God, COVID negative, and all of my patients actually had great outcomes.
Especially you're dealing with pregnant women, younger
Yes.
people, the babies, of course. So that's marvelous. And how about right now the precautions? Should anyone be afraid of going to the hospital or going to their obstetrician? And we'll talk maybe later about gynecology, but going to their primary care or their regular doctors during COVID?
No. In the hospital, in the offices, we sanitize. We take the utmost precautions to make sure we have a sanitary facility to see our patients. The staff is vaccinated. The physicians are vaccinated. Testing occurs regularly. So it's very, very safe at this point to go see your physician, go to the hospital, and seek medical attention.
Maybe I'll jump into a little controversy. So when we talk about vaccinations, COVID vaccinations, maybe we can even talk about other vaccinations for pregnant women. Tell me what are your thoughts about it, and there's always a governing board, the American College of
Sure.
Obstetrics, and who try to use, what we all try to do as physicians, use evidence-based medicine, that we have data to see how people are doing and how people have done. So what's your recommendations with regard to vaccinations?
I strongly believe that that our patients should be vaccinated. The American Medical Association, the American College of Obstetrics and Gynecologists, I mean, everybody shares the same belief. Follow the medicine, follow the evidence, and it is a recommendation to vaccinate. The controversy, I think, is more with our pregnant patients. They're a little more hesitant. You know, it is recommended that the pregnant patient does receive the vaccine. The evidence supports that it's safe, and it you know, it won't cause any issues. However, I can understand my pregnant patients are a little hesitant, are a little reserved, and they just worried. So I spend a lot of time in the office talking to these patients, trying to not convince them, but trying to make them understand that, you know, it's something that's recommended and I support. And I think that goes a long way when I tell the patients, you know, I support this. My children are vaccinated. My wife is vaccinated. My parents, you know, it goes a long way. So I'm a big proponent of, you know, patients speaking to their physician whom they usually trust. So we spend a lot of time with the COVID vaccinations and teaching the patients and trying to get them vaccinated, especially now with the new variant. We see it's affecting pregnant women a lot more. When COVID first hit, our patients were young, healthy females, and you know, usually came in asymptomatic. Now, for the first time in the last couple of weeks, I've seen patients being hospitalized, pregnant patients being hospitalized, pregnant patients being symptomatic. So I think it's very important now with the new variants that are coming out that we protect our pregnant patients.
Yeah, and that's wonderful, wonderful advice. So tell us about, we watch on TV, you know, there's the old joke, I play a doctor on TV and not in real life. I think we play one in real life, and we're on TV right now. So the question comes down to, is that 2 in the morning call? So when you have to go in to deliver a baby, babies don't come when they want it, when you want them to come, or even when their moms want them to come, or their dads want them to come, or family members who want to be around. Babies are born at all times of the day and night. And we always think of the obstetrician coming in at ungodly hours is a bad way that I would think about it. And no one out there could realize how tired you must be, or how could they function, how could they do it. So maybe give them a little bit of insight how you actually could do this and be able to still be sitting here when we're taping the show. So you're able to sit here, so I'm impressed. So somehow, are you up all night every night? Do you have coverage? How do you do it?
That's a great question. I wear scrubs. It's tough. It's tough. But, you know, we get used to it. Yeah, that 2 a.m. phone call when you're in bed wakes up everybody. And it's tough, but we're used to it because, you know, personally, I like what I do. And a lot of my obstetric colleagues, you know, you go into it because you like what you do. And it's not the patient's fault that it's 2 in the morning. It's when labor decided to come. Nobody can control that. So, you know, we get up, we're a little groggy, wash our face, and we're ready to work. You know, I think it's a lot harder on the family. It's a lot harder on the family during the holidays, you know, because you got to run out. You know, the beauty of my practice and my Richmond family is that I have coverage, and I have coverage. And the most important part about that coverage is coverage that I trust, that I know are going to do a great job for my patients. They're going to treat them as well as I would treat them. But more importantly, these are excellent doctors, and knowing that I can enjoy a holiday weekend, or I can enjoy a day off, because I know my patients are in excellent care. You know, it's difficult when you don't know who's covering, and there are some institutions that you don't know who's covering, and you're going to go and you're going to get whoever. But you know, thank God with my practice and my colleagues, we know each other, we work together. The patients have already met the doctors that are covering. It makes it a lot easier. But it's tough. It's tough. The patients, you know, I always say to myself, it's not the patient's fault. It's 2 a.m. in the morning, 3 a.m. in the morning. you can't get upset, and it's a beautiful thing to deliver a baby. We even have little bells that start ringing in the hospital when a baby's born. So, you know, even if you wake up and you're a little groggy, it quickly passes. So I tell my patients all the time, don't worry about waking me up. You know, whatever time it is, and it usually works itself out.
Even as a neurologist who hasn't done surgical type things in many years, I still remember that adrenaline rush as a medical student being there for the delivery of a child.
It's invigorating. You can't describe it. It's just and the joy in the parent's face is well, I could say is worth it.
So let's go all the way to the start. Pregnancy is how long?
Layman terms, 9 months. Yeah,
9 months, 36 weeks, 40 weeks. We all come up with different terms.
Yeah, we consider it 40 weeks, but you know, the general population, you know, has always been told it's 9 months. It's 40 weeks, and 2 of those weeks you're not really pregnant. So, but we consider pregnancy 40 weeks.
And when does someone get to the obstetrician? Say, how does someone know to? And it sounds like a really silly question. When you're pregnant, you go. When you have when you take the positive test, or you don't. There are patients we hear that are pregnant for months and don't realize they're pregnant. Is there a time to go to your gynecologist, and even more importantly, to your obstetrician? And how important, even if you get a positive pregnancy test, is it important that you go there soon, or could you wait a few weeks? I mean, give me a little bit of timing. What's your recommendation?
I think it depends on the type of patient. I mean, if she's a high-risk patient, which means if she has other conditions, if she has heart conditions, you know, any other diabetes, respiratory problems. So if she has other conditions, I think the minute she finds out she's pregnant, she gets a positive pregnancy test, make the appointment. Otherwise, if you're young and healthy, you find out you're pregnant, meaning you missed your period, you have your positive pregnancy test, I think 2 to 3 weeks is very reasonable. You'll start taking your prenatal vitamins ahead of time. You can go buy vitamins over the counter nowadays, and when you come to the office, we can prescribe. But you start taking your vitamins, make the appointment, be seen in 2 to 3 weeks. And the main reason is that we'll get a heartbeat. So when you come to the office, it's very important that we know where this pregnancy is, because some people are at risk for ectopic pregnancies not in the womb, in the tube, in the ovary, in the cervix. So I think 2 to 3 weeks, we'll know where the pregnancy is, we'll get a heartbeat, and then it starts. So that would be perfect, unless there's other conditions that require immediate attention.
Say someone's taking medication. The obstetrician, and I see this a lot of my patients who have multiple neurological issues, who are on chronic medications, whether it's seizure medications, medicines for headaches. All of us outside of obstetrics always defer to the obstetrician. And the obstetrician sometimes the obstetrician calls us up. And we try to make a decision together about the risk benefits of any agent. So tell us, what do you think, and what do you do with someone who's diabetic, hypertensive, and all the things that I was mentioning? How do you assess what medicines they should continue?
You know, in the perfect world, these patients would come ahead of time and have a consultation with us, tell us they're contemplating pregnancy, and then we can reach out to the different members of the team, their different doctors, and get a plan. You know, luckily a lot of the medication that people are on, you know, it's relatively safe, especially in the beginning where, you know, a week or 2 passes, we can make adjustments. But you know, unfortunately, this is not what I see. A lot of what I see is patients just stopping everything, and you know, that could be dangerous. Stopping your thyroid medication, which we normally wouldn't stop, stopping your anti-seizure medicine, which we would potentially change, but we would do it in a way that won't jeopardize the patient, because you know we don't want the patient seizing. Stopping your thyroid medication, which
diabetes medicine,
your high blood pressure medicine. You know, there are patients that come in hypertensive, and we don't want them stopping these. You know, we have patients with anxiety and depression, and sometimes it takes years and multi drugs to get them in a good place. We don't want them just stopping everything. So, I mean, ideally, patients like this, we identify ahead of time, we talk to them, they know to come the minute they become pregnant or when they're contemplating pregnancy, and we can reach out to doctors like yourself and get a nice team plan to get this patient safely through pregnancy. And you know, when that doesn't happen and they've just stopped everything or they just come in and they're still on the medicine, then we you know, try to reach out to the various physicians and manage what medicine they can stay on, what medicine aren't going to harm the baby, and go
So
from
really the
there.
recommendation is to continue your medicines unless
Yes.
things that you take on an as-needed basis we'd really try to avoid. Things that you take once a month or once a day, if you have a headache, you can take Tylenol. I mean, those kind of things we usually try to avoid,
Sure.
Motrin-like medicines. But the things you're taking on a daily basis, probably you should continue until they see you.
Yeah, and I think the take-home message is going to be, if you are on medicine that you take on a daily basis, as you said, speak to your gynecologist and obstetrician, you know, if possible, before you become pregnant or immediately when you find out you've become pregnant, because it's not too late to adjust everything in that early moment in time.
How often do you go to the obstetrician? So you're pregnant, you go there, you get assessed. Is it something that you go every? I have 3 kids, so I went. My wife had twins, so we went twice for pregnancy. So I knew how often you went. But about what's the pretty standard protocol?
The standard protocol is typically monthly in the first trimester. You know, our trimesters go. The first trimester goes to 14 weeks. The second trimester goes up to 28 weeks. The third trimester goes from 28 weeks to term, to 40. In the first 2 trimesters, we see patients every 4 weeks. In the second trimester, in the third trimester, we increase that to every 2 weeks. And in the last month of pregnancy, we bring patients back every week. And the reason for this is that, you know, things can come up later on toward the end of pregnancy that we need to be we need to be on top of. We need to be able to pick up on and deal with immediately. For example, preeclampsia.
Which is what?
Which is basically in pregnancy, a patient starts to develop high blood pressures and is passing protein in her urine, and you know, that could lead to eclampsia, which is the patient seizing. So these are things that can happen, you know, week to week, day to day. So, you know, at the end, we want to monitor pressures, and it's important to bring patients in weekly. Not to mention, you want to see the well-being of the baby at the end. Placentas are getting a little older, and you know, it's important to be able to see the well-being of that fetus at the end, because you know, once a patient is term, we can intervene at any time. So it's good to bring the patient back weekly at the end, and then once you reach the 40-week mark, which is the patient's due date, we bring you in twice a week. And again, because the placenta now is post your due date, and less nutrients could be passing through, and we want to be on top of any growth restriction, any issues that require us to deliver that baby much sooner.
How do you decide what kind of delivery someone has? I mean, we hear about cesarean sections all the time.
Flip a coin. No, I'm kidding.
He's kidding.
I'm kidding.
But
No, we prefer the vaginal route. You know, I tell my patients all the time, I don't want to work extra hard on a cesarean section. I want you to do all the work, but we prefer the vaginal route. The healing is better. It's natural, and patients will recover so much quicker. You know, but sometimes cesarean deliveries are necessary.
when are they necessary? How would someone know on their own without the obstetrician? Is it something, if you said my mom had 3 children all with cesarean section and my sister had a cesarean section, how would someone know?
You can suspect. I mean, the obstetrician would know. The only way the obstetrician actually would know ahead of time would be if the baby's not in the head down position, in the vertex position.
So tell us a little about that. How does the baby lay?
The baby can lay breech, which is basically with the butt down toward the pelvis. The baby's the way we like the baby to lay would be head down. We need the head to be the first thing coming out of the birth canal to deliver to be able to deliver vaginally successfully. The baby could be laying across too and diagonal, so that's transverse and oblique. So we need that baby to be in the head down vertex position, and when that's not the case, heading into the end of pregnancy, we can suspect a patient may need a cesarean delivery. Then there could be growth restriction that makes us suspect that the patient may not be able to tolerate labor. So other than, usually we won't know until we're in the labor process, but there are certain conditions that are not going to allow the patient to even have a trial of labor. And the main one is going to be the malpresentation, the baby not being in the proper position. So the patient doesn't know, and a lot of times we don't know until we're in the labor process, and at that point we're watching to see how the patient is progressing. The patient needs to be contracting in order for the cervix to dilate, and we're assessing the cervical dilation every 2 hours. We can help the contraction process and give some Pitocin, which is a medicine that your body produces naturally, but we can give it through the IV to make you contract a little stronger and help labor progress.
Is that what induction is? Because everybody talks about induced labor. Tell us a little bit what that is.
Induction is when you have to put someone into labor, and they're not in labor. So labor basically is a patient contracting and dilating. So painful contractions that are causing the cervix to open up and dilate. That's labor. When this is not happening and you're not in labor, but we have to, start to, we need to deliver your baby. We need to put you into labor to expedite delivery. The start to start labor is the induction process. So we try to do what your bodies naturally would do with spontaneous labor. So induction is when a patient is not in labor, is not contracting, is not dilating, and the doctor trying to put her into labor. We do that with sometimes Pitocin. We could do that mechanically. We have various balloons and mechanical methods to potentially help the cervix dilate. What I spoke about before is augmentation. We're just helping the labor along. So the patient is already in labor, and we're just augmenting it, making it better. And there will come a time that the patient will dilate fully and get ready for pushing, or not dilate and arrest. And that's when you typically, start thinking C-sections, when a patient is arresting, she's not dilating all the way.
When the process has stopped.
When the process has stopped.
Have you seen more cesarean sections or less cesarean sections over the last few years?
They've stayed stable, Dr. Perel. They've stayed very stable. It's anywhere between 20 and 30%. Nowadays we're monitoring the C-sections done on patients that have never had a C-section, that are patients that are coming in with the trial of labor. And the rates are about 20, 25%, and that's pretty much been consistent. It's never going to get to the rates from 20 years ago when malpractice was minimal, and I'm not going to say doctors were taking chances, but they would tolerate a lot more. But I think we're at a stable rate right now of about 25%. So 1 in 4 patients will come in first time and will need a C-section. But luckily the majority are still having vaginal births.
Tell us a little bit about complications of delivery. I mean, you're a surgeon. I mean, you're in the operating room. These are difficult things. These are large babies coming through birth canals. What kind of complications are you seeing, and how much better have we gotten over the years in treating them?
Some of the complications that occur during the labor process. I think you were alluding to big babies potentially getting stuck in the birth canal and leading to an Erb's palsy,
which is a weakness, and
which
is a nerve issue.
which is a nerve issue, which is typically caused from a shoulder dystocia, meaning the shoulder gets stuck, and a lot of times it's unnecessary downward traction on the head that could potentially cause that injury. You know, it's from experience, it's very difficult to, you know, you suspect it, but it's very difficult to know who's going to go, you know, who's going to encounter that complication and who's not. You know, I've seen patients deliver 10-pound babies with no issues, and I've seen 6.5-pound babies get stuck. However, I think the training that we're doing in the hospitals, we're teaching these young residents how to properly deliver these you know, how to properly deal with these complications. I think that's producing much better outcomes. You know,
I'm just so impressed with the monitoring of the baby. That's where I was worried about birth brain injuries, things like that could occur. And the monitoring is just so crucial.
Yeah, that's another complication. You know, these injuries in utero with brain injuries and cerebral palsy. A lot of it does come from that monitoring. I mean, we're watching that heartbeat on a continuous basis. We're trained to look at the monitor, to look at the baby's heart pattern, and you know, we're trained to basically interpret that. And I mean, it's basically the baby talking to us, and we're trying to determine how is the baby doing there, you know, in that position, in that time in labor. And you know, it's our job to try and interpret that, and to intervene if we think the baby is potentially, you know, in distress. The injuries typically happen from hypoxia and acidosis. It's where, you know, oxygenation goes down, the baby's system starts producing more acid. It's eating up the base. It's producing more acid, and that is what we see causes the injury in cerebral palsy, for example. And you know, the baby will show us clear signs most of the time that this is happening, and that allows us to intervene, and typically with a C-section.
In the last few seconds, first I want to say thank you, of course. Tell me about your team. I mean, I know you have a wonderful team. Your team has a wonderful reputation, as you do. Tell us about the team, and as I said, real briefly, because we only have about 30 seconds left. See, you know, they'll be upset with you if you don't talk about them.
Richmond University Medical Center, Dr. Campanella and Dr. Sabia Akbar, that's my team. We work well together, and I trust them.
And your nurses, of course.
My nurses are some of the best. My PAs, the nurse practitioners, our ICU, our neonatal ICU. I mean, we have a great team around us, and we trust each other, and I think that's what gives the best care to our patients on Staten Island.
Simon, I want to say thank you. This was a quick half hour. We could be talking about obstetrics for hours and hours. And I think it's just so enlightening to, when we talk to the public, to get an idea of what kind of doctors stay up at 2 o'clock in the morning and how dedicated you are to delivering babies, and the happiness that you get and the happiness that the family gets in having delivered a child to this world.
Thank you very much.
So thank you.
Thank you.